Hope Cook with Dermcast.live. Today we have Dr. Lisa Swanson. Dr. Swanson is an Idaho pediatric dermatologist and a rock star lecturer.
Oh, that's nice.
She's also our medical director for the San Diego conference.
Yes, it'll be a blast. Everybody should come.
That's right. All right, so you are a wealth of information, but I decided to narrow it down to pediatric atopic derm and pediatric psoriasis.
Cool, I think I can handle that.
A lot of us get stumped when we see kids with psoriasis.
Yes.
Because we're used to seeing big people with psoriasis.
Yes.
So when you see a kid with psoriasis, what should we be thinking? Should we screen for anything?
So I think the number one thing with pediatric psoriasis is simply knowing that it's out there. There's this rumor that kids don't get psoriasis, and I can tell you they definitely do, and that the incidence is increasing pretty steadily. I have been in practice 13 and a half years. When I first started, I would see one new pediatric patient with psoriasis a month, and nowadays it's one every day. And it's been that way for the past 5 to 6 years. And it was true when I was in practice in Colorado. It's been true in Idaho as well. So pediatric psoriasis is out there. It is increasing in its prevalence. It's being misdiagnosed every day, often by primary care providers, not so often in the dermatology world, but it's being called atopic dermatitis, it's being called tinea, and some kids, particularly with inverse psoriasis in the underwear area, they get treated for months for yeast, just over and over with oral and topical therapies until somebody says, oh, maybe we should have derm take a look at this. And then it's clear it's inverse psoriasis and we get them on appropriate treatment. So the number one thing with pediatric psoriasis is know it's out there, know it exists, and know that psoriasis is a systemic disease of systemic inflammation, and as a result, there are systemic consequences. We know all about the comorbidities of people with psoriasis, and those things are true in kids too. Increased rates of diabetes, high blood pressure, anxiety, depression, all of these things. And if we can help a kiddo with their psoriasis and hopefully help mitigate their risks for those comorbidities, then that's definitely something I'd like to try to do.
Yeah, so you have to have a conversation with the parents about their levels of inflammation.
Yep. And you know, I think any patient with psoriasis, it's definitely appropriate to start with topical therapy, and we have a couple relatively new topical non-steroidals approved for psoriasis that it's wonderful to have. And there are a lot of patients with psoriasis that can be well managed on an appropriate topical regimen. But if a kiddo has passed that point and they are struggling, I wanted to inspire attendees at the conference to not be afraid to pursue systemic therapy for these youngsters because they really have a lot to gain and a lot of benefit to have by experiencing these medications to help their life get better.
Yeah, it really can change their little lives.
Yes. It's wonderful.
And what do you say to parents who are really hesitant to even discuss biologics?
Yeah, I first talk about the fact that all biologics are not created equal. There are so many commercials for every biologic under the sun, for every indication under the sun. And sometimes people just watching those commercials assume they're all kind of the same with the same risks and factors and everything like that. And so first I just kind of clarify that these are specific biologics intended to treat psoriasis in a focused way to turn down that aspect of the immune system that's turned up in psoriasis. I talk to them about the favorable safety profile of these medicines, that a lot of them have been studied for years and years and years. The fact that we have 4 biologics approved in our pediatric patient population, which is really wonderful. Even if you're not treating kids, talking to your patient about a drug that's approved down to the age of 6 is very meaningful, you know? And so I share that information with them. I also will talk to them about the potential systemic consequences of the inflammatory process of psoriasis, and that yes, we're using these medications to treat their skin, but we're also hoping it helps with the other stuff too, and that can be a reason to pursue systemic therapy. We aren't getting to those sorts of points of impact with our topical medications. And so I will kind of take a 3-pronged approach talking to them about those particular factors.
And do you screen for those comorbidities?
I do, and there are actually guidelines out there that were in the JAMA Derm journal way back in 2017 on when to screen for things like diabetes, high blood pressure, and to talk to your patients, even youngsters, especially teenagers, about, are they smoking? You know, are they doing anything like that? How's their mood? Are they experiencing any symptoms of depression? How are things going at school? How is their coping mechanisms when they have psoriasis? Are people asking them about it? All of these things. So yes, we try to take kind of a holistic approach, looking at the whole little child and how they're experiencing their psoriasis and checking for any potential medical comorbidities that could occur.
Okay, and speaking of holistic, do you get a lot of questions about diet with psoriasis?
I do, and I say, you know, in medicine, it's all about the data. What do we have the data for? What can we tell our patients has been shown to be safe and effective? And with things like dietary intervention, we just don't have a ton of data. There has been some evidence that fish oil or eating fish, you know, once or twice a week can be beneficial for psoriasis. There have also been some studies on curcumin for psoriasis. And so I'll share those couple things. I will also typically tell families that I'm not aware of any dietary things that would worsen the psoriasis. I think sometimes that question is coming from, is there anything we're feeding our kiddo or our teenager that's contributing to this? Are we causing this in some way? And so I will allay those fears and say, no, it's nothing you're doing. It's nothing he's eating. You know, he just has this inflammatory skin disease, and we're going to treat it and make it better. In fact, I tell a lot of kids with psoriasis, I say, it's a good time to have psoriasis because I have more tools in my toolbox than ever before.
Yes. What about IL-17s?
Yes, IL-17s, yes.
Do you need to screen for IBD?
So that's a very pertinent question. So 2 of our 4 biologics approved in the pediatric patient population are IL-17 inhibitors, ixekizumab and secukinumab. And with these IL-17 inhibitors, we have to at least think about inflammatory bowel disease. And there's still controversy about it. Are these medicines causing something, or are they simply not treating inflammatory bowel disease? And patients with psoriasis are a predisposed patient population, and so we're seeing this kind of underlying increased incidence come to life. So there's still debate about that. But especially if you're treating a young person who probably hasn't had time in their life to maybe develop a whole lot of the features of full-blown inflammatory bowel disease, it does make you a little bit edgy. You know, what should I be doing to best serve my patient and make sure they're safe? And so I talked with a lot of pediatric gastroenterologists when these IL-17s got the approval for pediatric psoriasis about what I should be doing, what questions I should be asking, what labs should I be considering. And I came up with a list that's what I use in day-to-day practice. So I asked 4 questions. I asked about family history of inflammatory bowel disease. Family history of Crohn's increases your risk by 8 times.
Wow.
I ask about growth issues. One of the most common symptoms of Crohn's disease in kids is they're falling off the growth curve. And the #1 associated comorbidity with pediatric psoriasis is obesity. So if you have a kiddo with pediatric psoriasis and they're falling off the growth issue, something's going on. #3, I ask about nocturnal diarrhea or nocturnal bowel movements. That's a key symptom for pediatric Crohn's. And lastly, I ask about perianal issues, pain when going to the bathroom, blood on the toilet paper. And then the 3 labs that I typically will order, I'll check a CBC to assess for anemia. I'll check a CRP. If all you have is psoriasis, your CRP should be normal. But it's elevated in conditions like psoriatic arthritis, obesity, and simmering inflammatory bowel disease. And then the last thing I check is something called a fecal calprotectin level. So this is a test that's done on a stool sample. You don't have to do it in your office, don't worry. It's not an in-office test. But you write your order just like you otherwise would in the computer or on a piece of paper, however you normally do it. The patient takes the order to the lab. The lab gives them a container. They take that container home, they submit their sample when they feel comfortable, and bring it back to the lab. But it's a very sensitive and specific test for inflammatory bowel disease. When elevated, it has great sensitivity and specificity for IBD. And apparently, calprotectin is something that's secreted by neutrophils in the gut. So if you're having an inflammatory process going on, you have more newts in there, and they are secreting that calprotectin. So that's why it is elevated in IBD.
Those are such good pearls. So you order that on any kid before you put them on a biologic?
I do. An IL-17 inhibitor, I do. And, you know, maybe it's a little bit overkill, but it's how I feel okay.
Yeah.
I feel like I'm doing everything I can for the safety of my patients.
Yes. Okay. Excellent, Pearls. Thank you for that.
Yes,
now we'll switch to atopic derm.
Okay.
All right, so we all see kids with atopic derm.
Yes.
Can you give us just a rundown of like things we should be looking for when parents ask about food allergies and?
Yes, oh my gosh, yes. So there's a lot of misconceptions out there in the world about atopic dermatitis and its potential relationship with food allergies. The overwhelming majority of the time, the eczema has nothing to do with a food allergy. Some studies say that 98% of the time it's got nothing to do with a food allergy. And if it does have something to do with a food allergy, it's honestly going to be pretty obvious. Within 30 minutes of eating said food, you would notice the eczema get a lot worse, or other symptoms like vomiting, hives, those sorts of things. And so when there is an actual food allergy, it's relatively obvious that there's a food allergy going on. And often what I tell patients and their families is I'll say, I wish this was a food. My life would be a whole lot easier if I could just tell every atopic derm patient and family that all they needed to do was just avoid egg and everything would be all right.
Yeah, get off your dairy,
yes,
you'll be good.
Right, right. But it's just not the case the overwhelming majority of the time. And food elimination is not something that we take lightly. We know that avoidance leads to increased risk of food allergy. Kids need their nutrition, and kids with bad atopic dermatitis tend to be small on growth curves. We need them to have every ounce of nutrition that they can get. And it's so rarely helpful. You know?
Yeah.
So families don't need to go down the food elimination pathway. We can treat the atopic dermatitis and make it better for them without needing to put them through that. There's also an increased number of studies showing that allergies might actually be being caused by the eczema. So the theory being that aerosolized food particles are able to enter through the skin where they interact with the immune system and stimulate allergy.
That makes sense.
Right? And there was even a study recently that looked at kids with atopic dermatitis with facial involvement versus those with atopic dermatitis and no facial involvement. And they found higher incidence of food sensitization in those kids that had facial involvement, which also, goes to kind of support that theory. And so really the best thing you can do to prevent food allergy is treat your child's eczema, help that get better, and prevent food allergy along the way.
Yeah.
Yeah.
Okay, that's perfect. What about families that have a strong atopic history? Mom's asking like, okay, I'm thinking about getting pregnant. Is there anything I can do this go round?
Yes. This is an area of hot research because we believe that there's this window of opportunity in early baby life that determines who gets atopic dermatitis and who doesn't. And we don't have the full picture yet. We have little puzzle pieces that we're still trying to put together. But our preliminary information indicates that flora, both in the gut and on the skin, are contributing to who gets atopic dermatitis. And we know that if a pregnant woman takes oral probiotics a month before she has the baby to 3 months after she has the baby and breastfeeds, it reduces the risk of eczema in that baby by 20 to 30%.
Oh, wow.
Whereas if you give a person with atopic dermatitis oral probiotics, it has no impact. So there's this window of time where all of this immune system activity is happening. And once we have all the pieces to that puzzle, man, it'll be awesome.
Yeah.
We will be able to provide really good information to our patients and their families on meaningful ways to prevent atopic dermatitis. We're not there yet. We just have pieces to the puzzle, but it boils down to both skin flora and GI flora, and we're getting there. We're learning lots.
Yeah, I mean, even saying that together, prevent atopic derm, like that's
Can you
huge.
imagine?
Yeah.
And if we were able to prevent atopic dermatitis, could we prevent allergies? Could we prevent asthma?
Yeah.
Could we prevent EOE? I mean, the sky's the limit.
Yes. Okay, we know to start with topicals if it's, mild eczema. But what about systemics? You have a parent who's like, I don't know, I mean, it's a shot.
Yes. So dupilumab is approved all the way down to the age of 6 months. That's a huge deal.
Yeah.
Both for a family with a young child that's considering the medication, but for everybody. The parent feels better knowing the drug is approved down to 6 months. The provider feels better knowing the drug is approved down to the age of 6 months. It's just such a vote of confidence for the safety of the medication. And we've been using dupilumab now for 6.5 years. It's a medicine we really know very well. All of us have prescribed it, and we all have a good level of experience with it. So that also lends a lot of comfort to the conversation. When I am talking to patients about dupilumab as an option, I typically will just kind of throw it out there amidst the other options and see what comes flying back at me. Sometimes the families jump at the thought, you know, they didn't even know it existed. It sounds great. They love the idea. Other families, there's a mixture of reactions. Some families feel like, oh, we're not that bad. You know, we don't need to go that far. And I often will say a couple of things. Number one, I think some families don't fully realize the impact that the atopic dermatitis is having on them until they go on a medicine that fixes it so well.
Yes.
And they're like, oh my gosh, I can't believe I was living that way.
Yes.
There's that expression, you can boil to death in a slowly heating bathtub. And I think eczema can be that slowly heating bathtub for a lot of families where they just don't realize. The other thing that I talk about with families is that it's appropriate to consider all the side effect profiles of the medications we're considering, but it's also appropriate to think about the safety profile of not adequately controlling your child's atopic dermatitis. That has consequences. And I talk to them about the impact on things like growth, which always is a big topic for them. You know, I try not to take offense to the fact that growth is a big thing because I'm 5'1.5" on a good day. But whenever I mention the troubles with growth impairment, families, their ears perk up with that.
Give me the shot.
Yes. They're like, okay, we're ready. I talk about sleep and sleep disturbance. I talk about the increased rates of things like ADHD, anxiety, depression, learning disabilities, autism spectrum disorder, all of these things. And we have some data to suggest that excess IL-4 could be the reason specifically for the increase in things like ADHD. There was a study published in our Pediatric Dermatology journal a couple years ago using mouse models, and it supports the theory that excess IL-4 could actually be responsible for all of this.
Wow.
And here we have this medicine dupilumab that works to inhibit IL-4. Can we have meaningful impact on these other things too? And I think we can. And I think that way both based on my personal experience, I've seen it right before my very eyes, kids that are totally ADHD off the walls, and then they go on dupilumab and they're just like calm and coloring, and it's amazing.
Wow.
And then there was also a relatively recent article in our JAD journal looking at the use of medicines for ADHD before and after patients started dupixent for their atopic dermatitis, and found a marked reduction in the need for and usage of ADHD meds once they started dupixent.
That is going to change a lot of parents' minds.
Right? Yes. So that's kind of how I approach it. And I also, there's no pressure.
Yeah.
You know, I tell them about the options available. I answer their questions. I give them the information that they want, the level of information that they want about it all. And I really let them decide. I often tell them, I'm the navigator, you're the captain. It's my job to tell you what the options are. It's your job to choose which way we go.
Yes. Okay, I love that.
Yeah.
Let's see, JAK inhibitors.
Yes.
So tell me what your conversation is like when maybe you start talking about those and parents are like, wait a minute, I've heard of that, but when I Google it, there's bad stuff.
Oh, I know, right? Yes. So I often tell them, I say, speaking in the context of atopic dermatitis, I say we have these oral medications in a family of medicines called JAK inhibitors, and they work very fast to help with atopic dermatitis, especially with regards to itch. They're really powerhouses for itch. And they can really be life-changing for so many patients that go on them for their atopic dermatitis. They do have a little bit of safety baggage, which I can sum up in 3 things. Number 1, we do have to do blood work for these medications. Number 2, they do increase the risk for certain viral illnesses like cold sore virus and shingles. And I ask if they've had a history of cold sores and if they are interested at all in the shingles vaccination, if they're of an appropriate age for that. And then I say number 3, there's a boxed warning on all JAK inhibitors that stems from a study on a different JAK inhibitor used in a different disease state, in a different patient population, and the patients who were in that study were on other concomitant medications, and because of some safety concerns from that study, the FDA thought it prudent to put this warning on all JAK inhibitors. I have reviewed your past medical history and your medication list, and I think the benefits of this medication far outweigh the risks. And so that's how I manage it, because that was a real struggle, like when these medicines first came to market, how to thoroughly yet efficiently describe the safety profile of these medicines without scaring a patient, without bogging down your clinic, but really getting that information out there, having it delivered in an absorbable way. That took me some practice, but I think I like that now. Yeah,
I'm going to hit replay on that.
Yeah.
So with live vaccines in pediatric patients, how do you time that?
So live vaccines, let's talk about dupilumab first with regards to live vaccines, because with dupilumab, non-live vaccines have been studied and are safe. They looked at it and they're safe, they're okay. We only have to worry about live vaccinations, and per FDA label, live vaccines are to be avoided while on dupilumab. In the original studies, what they did was they gave the dupilumab, they waited 3 months, they gave the vaccinations, they waited 1 month, and they restarted the dupilumab. And so I tried to do that. It was really hard to have these patients off drug for 4 months.
You're starting over.
Oh, it was really difficult. And so what most pediatric dermatologists are doing these days is we'll give the dupixent, we'll wait 1 month, they'll get their vaccinations, we wait 1 month, they restart dupixent. So they're basically just skipping 1 shot of dupixent. And so that is the protocol that I follow these days. Now the JAK inhibitors, that's a little bit of a different story. And to be honest, the live vaccine question affects dupilumab the most because the 2 most common live vaccines are MMR and chickenpox, and those are given between the ages of 1 and 2, and again between the ages of 4 and 5. And so it's really those windows of time where this has to be most on your radar, and that's where dupilumab is approved in those age groups. But the JAK inhibitors are not, being age 12 and up. And so right now, the label is to avoid vaccines on the oral JAK inhibitors, take some sort of hiatus if you need to get a vaccination, encourage patients to catch up on vaccinations before you start the medication. And so those are the rules and regs that we're trying to follow for the oral JAKs. And fortunately, it's not in an age group where we have to think much about the live vaccines.
Okay, perfect. Any other tips or pearls you wish we knew as providers?
Oh boy. I guess the one thing that I really like to talk about is with these oral JAK inhibitors, they have the capabilities to impact our patients in ways that we have not seen before. For conditions like atopic dermatitis, for alopecia areata, for vitiligo, and more to come. These JAK inhibitors can do so many things. And I think a lot of providers have been scared away by the boxed warnings and have been kind of shying away from them. I would encourage them not to do that. Get comfortable with the warnings. Get comfortable with the safety profiles. Talk to people you respect, providers you hear at conferences, people that you work with. Medical science liaisons are available for these medications. Really submerge yourself in it to a point that you feel comfortable and confident, because these medicines are too darn good to just dismiss because of a warning.
You owe it to your patients.
You owe it to your patients to give them the options available, and these are some pretty tremendous options.
Yeah. Oh, this has been so helpful.
Good.
I have a few rapid fire questions that have nothing to do with dermatology.
Oh, great. Okay.
All right, what was the last concert you went to?
Oh man, I wish I could say Taylor Swift, but shoot, no, I missed out on the Eras tour. Although I'm going to try next summer because I really would love to see Taylor. Last concert I've been to was actually Phil Collins. I saw and it was amazing. I saw Phil Collins in Las Vegas. It was a while ago. It was before COVID. I haven't been to a concert since COVID, but it was awesome.
Perfect.
Yeah.
Okay, if you had to get up and sing karaoke right now, which song would you pick?
Oh, yeah, Total Eclipse of the Heart by Bonnie Tyler. Yeah, without a doubt, Total Eclipse of the Heart.
You know they have karaoke tonight.
Oh, I didn't. Oh, I didn't. Man.
All right, and what would be a fun alternate career to dermatology? So you're not a dermatologist.
Not a
What would you
dermatologist.
be?
Well, growing up, I wanted to be a wide receiver in the NFL. I literally did. I like practiced with my dad. I joke that I was the son my dad never had, and I have a brother.
Yeah.
But like I was like the sports person. And so we practiced every weekend, and I went to all sorts of games and even training camps and stuff. I was really big, wanted to be a wide receiver. But then when I maxed out at 5'1.5", I was like, okay, this dream has to die. And so I fell back on dermatology. So a career in pro football, that would be pretty neat.
Yes.
I also think it would be fun to be like a host of the Today Show.
Yes. See, this is kind of Today's Show-ish.
Yeah, I feel very much like I'm on the Today Show.
All right. Thanks, Dr. Swanson. We appreciate you being here.
Thank you. Thanks for having me.
Hope Cook with Dermcast.live.